development of the first affiliated hospital of Fujian Medical University. Welcome to my class. Very glad to see you all in the internet. This lesson, we are going to learn blood chemistries, the liver function and other enzyme tests. The outline include introduction, basic concepts for diagnostic enzymology, liver diseases, markers of liver diseases, and patterns of liver enzymes and markers for interpretations of disease. First, I will give an introduction of enzymes. Enzymes are biological molecules that catalyze chemical reactions. In most cases, they increase the rate of chemical reactions. And enzymes are in general globular proteins. Enzymes are high molecular weight compounds made up principally of chains of amino acids linked together by peptide bonds. This picture shows a typical protein structure, two amino acids joined together by a peptide bond. In enzymatic reactions, the molecules at the beginning of the process, called substrates, in Chinese 底物, are converted into different molecules called products, in Chinese 产物. Many enzymes require the presence of other compounds, cofactors, before their catalytic activity can be exerted. This entire active complex is referred to as the holoenzyme. An apoenzyme plus the cofactor is called the holoenzyme. Apoenzyme is the protein portion of the holoenzyme, and cofactor can be coenzyme, phosphatic group, or metal ion activator. Enzymes can be classified by the kind of chemical reaction they catalyzed, such as addition or removal of water, transfer of electrons, transfer of a radical, splitting or forming a carbon bond, changing geometry or structure of a molecule, and joining two molecules through hydrolysis of pyrophosphates bound in ATP or other. So, we know that enzymes have many important physiological functions in our bodies. They play vital roles throughout our lifetimes, from growth, maturation, and reproduction. Here I changed Kobe Bryant's photo into black. Kobe Bryant has passed away earlier this year, and I will miss him forever. Alright, next one is about diagnostic enzymology. We know that blood tests are simple, harmless, hurtless, and we can get the result rapidly. Alright, so diagnostic enzymology is widely used now, and even the first choice of diagnose some diseases. Diagnostic enzymology involves the measurement of enzymes in body fluids for the diagnosis of disease. Obviously, the most useful body fluid is serum or plasma, while urine, cerebrospinal fluid, and extracellular fluid are sometimes also very useful for some specific disorders from specific parts of our bodies. Diagnostic enzymology is useful in clinical diagnosis of organ and tissue damage. As we know, liver plays a major role in metabolism and has a number of functions in the body, including plasma protein synthesis and others such as secretion and excretion of bile. Okay? And some enzymes also come from myocardial and skeletal muscle and pancreas. In this chapter, we will focus on the analytical aspects and clinical significance of important enzymes that are measured for diagnostic purpose of liver diseases. Let's take a look at the basic concepts for diagnostic enzymology. We have to notice that most enzymes used for diagnostic purposes have no direct effect in circulatory system. Alright, no direct effect. Pathologically, disorders or damaged cells change the level or activity of enzymes, and then they release into blood. Right? They have no direct effect in circulatory system. And physiologically, blood enzymes are released as a result of nature aging and turnover of cells, and they are cleared by metabolism within the reticular endothelial system and kidneys. The level or activity of blood enzymes is a function of the rate of release and clearance. Okay, now, here is about the half-lives of enzymes. The half-lives of blood enzymes vary greatly from 2 hours for the BB isoenzyme of creatine kinase to 170 hours for placenta alkaline phosphatase. And generally speaking, the shorter the half-lives of enzymes, the more accurate of diagnosis of acute diseases. Alright? Okay, now, the isoenzymes. It is very important, alright? What is isoenzyme? Isoenzymes are enzymes that differ in amino acid sequence but catalyze the same chemical reaction. For example, the enzyme LDH. LDH is made of two different subunits, H form and M form. They combine in different permutations and combinations but catalyze the same chemical reaction. They distribute in different tissues and organs, and in different tissues and organs, they have different concentrations. So, we may know the source of disorder according to the measurement of the concentrations of isoenzymes. Alright? Pathologically, high levels of enzymes indicate directly of disease or indicate the tissue synthesis of new enzymes that occurs in response to disease. Let's see the first one, indication of disease. In 1954, some scientists published an article named Serum GOT Activity in Human Acute Transmural Myocardial Infarction in Science. GOT is called AST currently, right? In this research, these scientists found AST activity increased after acute myocardial infarction. And then, they used carbon tetrachloride to induce liver injury in rats, and they also observed the AST activity increase. These investigators showed high serum enzyme levels were caused by leakage from the damaged hepatocytes, so they do believe elevated enzyme indicate several diseases. And the second one, high levels of enzymes indicate tissue synthesis of new enzymes that occurs in response to disease. For example, obstructive liver disease result in the increased synthesis of hepatic ALP because of abnormal intracanalicular pressure, alright? And phenobarbital and some other drugs result in the increased synthesis of microsoma enzyme, which lead to the elevated level of GGT. And for primary liver cancer, the level of ALP is elevated. Alright. Why in primary liver cancer the ALP is increased? Because hepatoma cells are undifferentiated or low differentiated blast cells, alright? We know that only blast cells can secrete fetal protein. Okay, in diagnostic enzymology, the goal is the measurement of the activity or concentration of the enzyme itself. There are two enzyme assay procedures. First one, kinetic assays. Kinetic assays are traditional methods to detect enzyme activity. Now we have a new method, immunoassays. The development of immunoassays has allowed us to detect enzyme concentration rather than enzyme activity. Alright? It is particularly useful for isoenzyme measurement. We know that the low activity of enzymes may be hard to test in blood, but the new method uses concentration to judge. So, enzymes here do not need to be present in an active form. Alright? The new method is equivalent to the old method sometimes, and in more scenarios, it is much more better. It is much more efficient. Okay? Alright, here's about the unit. IU is commonly seen in diagnostic enzymology. An IU, international unit, is defined as the amount of enzyme necessary to catalyze the conversion of 1 micromole of substrate per minute. Okay, the third part. Let's talk about the liver diseases. Liver is the most rich enzyme-containing organ, accounting for 67% of the total enzyme proteins are synthesized in liver. The complex biotransformation and metabolism of the liver mostly completed with a series of enzymatic reactions. Some pathological state of the liver often leads to changes of the serum enzyme concentration. And enzyme assays help diagnose or differentially diagnose liver diseases as well as assessment of therapeutic efficacy and prognosis. Here are some very common markers for liver diseases, include ALT, AST, GGT, ALP, LDH, and bilirubin. Why here I say markers, not enzymes? Alright, because bilirubin, okay? Bilirubin is not enzyme. Okay, liver diseases can be divided into 4 types according to etiologies. First one, acute hepatocellular injury. The second one, cholestatic liver diseases. Third one, chronic liver diseases. And the fourth one, alcoholic liver disease. And next, let's see them one by one. First one, acute hepatocellular injury. Acute hepatocellular injury often include acute viral hepatitis and acute liver failure. The pathological feature of acute viral hepatitis is infiltration of monocytes and hyperplasia of parenchymal hepatocytes. It is called ballooning degeneration. and it presents active hepatocellular destruction and cell damage, a variable degree of biliary obstruction. The capacity for bilirubin metabolism is considerably reserved in acute viral hepatitis, so the patients are often only mildly jaundiced. The acute phase of disease typically lasts 3 to 6 months. AST, ALT, bilirubin are commonly used for acute viral hepatitis. This is the picture of hepatitis A virus under electron microscope. Okay. Moreover said, hepatitis A virus is single-stranded RNA virus, alright? The virus spreads by the fecal-oral route. The cause is the food or water you eating or drinking is contaminated with HIV-infected feces, alright? And this is the photo of hepatitis B virus under electron microscope. HBV is double-stranded DNA virus, and in this picture, we can see the infective virus particle, which is called Dame particle, alright? Okay, when it comes to acute liver failure, it is characterized by extensive hepatocellular necrosis and very high mortality. It has several etiologies. It is the progression to fulminant hepatitis. And the most common cause is toxic hepatitis. Serum bilirubin, AST, and ALT are largely increased for acute liver failure. This figure lists some common causes of toxic hepatitis, such as some chemicals, the poisonous mushrooms, alright, metals, some kinds of drugs, and some metabolic reasons, such as Ray's syndrome, Wilson's disease, something like that. These toxins are conjugated within the liver to inactive metabolites and excreted into the urine. The overdose results in a saturation of the hepatic conjugation capability. As a result, highly reactive neutrophilic intermediates bind to hepatocytes, cause liver damage. Okay. Alright, the second one, cholestatic liver diseases. Okay. Cholestasis results from suppression of bile flow and can be either extrahepatic or intrahepatic. Serum levels of liver enzymes and bilirubin increase only when more than 80% of the hepatocellular functional capacity has become impaired. So, if for early screening, these enzymes may not sensitive enough. In early stage, ultrasonography, liver puncture, and some autoantibodies assessment may be necessary, okay? And enzyme markers of obstruction include ALP, GGT, and 5-NT. An intrahepatic obstruction often results from cirrhosis or hepatitis or administration of some drugs. It manifests as precipitation of bile salts. The etiology often include idiopathic familial intrahepatic jaundice in the 3rd trimester of some otherwise uncomplicated pregnancies, or some other congenital disorders such as Dubin-Johnson syndrome and Rotter's syndrome. An extrahepatic obstruction is an obstruction of the bile duct or hepatic duct, okay? For example, cholelithiasis, or the obstruction caused by carcinoma of the tip of the pancreas, or a result of the inflammatory processes such as pancreatitis and bile duct lesions seen in sclerosing cholangitis. Okay, the third part, chronic liver diseases. Chronic liver diseases often include chronic hepatitis and liver cancer. Chronic hepatitis is a disease with diverse etiologies, including viral, autoimmune, and leukoid reasons. The active form is characterized by monocyte infiltration and hepatic necrosis. The pathological feature of chronic active hepatitis is disruption of lobular architecture and fibrosis, even cirrhosis. And chronic persistent hepatitis is a kind of a milder disorder that rarely progresses to cirrhosis and fibrosis. So, chronic active hepatitis is much more severe than chronic persistent hepatitis, okay? And here, bilirubin and some enzyme markers tend to be more elevated. Okay, the liver cancer. In China, the most popular hepatitis B virus infection area, liver cancer often occur in patients with long-standing hepatitis B infections and liver cirrhosis. And primary liver cancer is prevalent among Oriental and Black African males, while Metastatic liver cancer is common in the United States, particularly from tumors that originate in the colon, lung, breast, and skin. Enzyme levels in liver cancer are usually elevated, and destruction of surrounding normal tissue and obstruction of normal architecture by space-occupying tumors are shown on radiological image. Okay, the next one, alcoholic liver disease. Alcoholic liver disease is associated with acute and chronic alcoholism. There are 3 stages: fatty liver, alcoholic hepatitis, and cirrhosis. An alcoholic fatty liver often have different level of hepatomegaly. The liver contains large triglyceride-containing vacuoles. Okay? It is benign, and it can be effectively reversed by immediate abstinence from ethanol intake. Liver enzymes are typically within the normal range, and the definitive diagnosis is liver biopsy. When it comes to alcoholic hepatitis, hepatocellular injury and degeneration are often irreversible. Hepatic infiltration by neutrophils and lymphocytes causes acute inflammation. It is chronic and progressive, and even can be fatal when it presents GI bleeding and hepatic encephalopathy. Alcoholic hepatitis is the precursor to cirrhosis. Enzyme concentrations increase here, notably for AST and ALT. The levels of them are commensurate roughly with the degree of acute hepatocellular injury. Alright, the third stage, cirrhosis. What is cirrhosis? It is chronic liver disease that leads to an increase in diffuse fibrosis and progression toward a nodular architecture. The etiologic factors include liver damage secondary to drug use. Chronic hepatitis obviously include alcoholic hepatitis and biliary obstruction and metabolic disease. Alcoholic cirrhosis is common in the United States and Western Europe, while chronic hepatitis B virus cirrhosis is common in Asia and Africa. Enzyme levels are variably elevated or can be normal. Alright, PBC. Okay, PBC is the abbreviation of primary biliary cirrhosis. PBC is another important cause of cirrhosis. It is an impairment of bile excretion and has been linked to an autoimmune process, and it has gender discrepancy. It affects women more often than men. The pathological feature is inflammation and destruction of bile ducts. High titers of anti-mitochondrial antibody along with elevation of ALP and ALT are presented. And moreover said, according to the updated guideline, PBC is renamed as primary biliary cholangitis, also PBC. Why here change cirrhosis to cholangitis? Well, because less than 1/3 patients progress to cirrhosis if intervention is taken early and properly. Okay? Alright, the next part, let's focus on the markers of liver diseases. This figure lists some markers for the pathological evaluation of liver diseases, such as ALT, AST, LDH for hepatocellular injury, bilirubin, ALP, GGT, 5-NT, bile acids for obstruction, and the indicators of viral and autoimmune serologies for infections, and CEA, AFP for malignancies. And this is the diagram of outer structure of a hepatocyte. We can see that different enzymes exist in different parts of a hepatocyte. And these markers are what we are going to talk about next: ALP and ALP isoenzymes, GGT, AST and ALT, LDH and LDH isoenzymes, and bilirubin. First one, ALP and ALP isoenzymes. Okay, phosphatases is a collection of cellular proteins, which is located mostly within the cell membrane. The function of phosphatase is to transport inorganic phosphate from donor to receptor molecules. And alkaline phosphatase is the phosphatase with catalytic activity at a pH of 10 or higher make up the collection. The level of ALP is dependent on the age and bone growth. The reference ranges of ALP in children is higher than that in adults. This figure shows the relationship between age and the concentration of ALP and ALP isoenzymes. From this picture, we can easily find out that children have higher reference ranges than adults, especially in adolescence, and older populations also have increasing ALP reference ranges. That means the increased possibility in the incidence of osteoporosis in older population. Okay, so this figure reflects the level of ALP is related to the metabolism of bones. Okay, for human, ALP is present in almost all tissues, but particularly concentrated in liver, bone, kidney, placenta, bile duct, and GI tract. ALP is an important indicator of many diseases, such as hepatobiliary disease, intestine, kidney, and skeletal disease. And ALP isoenzymes are distributed in different organs and tissues, and the level of ALP isoenzymes are used to differentiate disorder sources between bone and liver by electrophoresis. In the past, sometimes we use Zuner electrophoresis to distinguish ALP isoenzymes. But with the technical difficulty with Zuner electrophoresis and increasing use of more specific enzyme markers for hepatic obstruction, the clinical need for ALP isoenzymes is real now. Okay, the next one, GGT. GGT is located in the cell membrane of nearly all human cells and tissues. The function of GGT is to transport amino acids into the cell. The reference range of GGT is 9 to 50 units per liter for men and 8 to 30 units per liter for women at 37 degrees. It is mostly from the liver and a small amount from the prostate, so it may explain why the reference range for men is slightly higher than the reference range of women. Okay. An increased level of GGT is an indicator of hepatobiliary diseases and alcoholism. Alright, the third part, AST and ALT, they are very commonly used and very, very important. Okay. ALT is the most commonly useful enzyme in diagnosing liver diseases. ALT is mainly found in the cytoplasm of hepatocyte, and ALT has only one isoenzyme. But AST has cytosolic and mitochondrial isoenzymes. Clinically, ALT is usually in conjunction with AST to evaluate liver diseases, but with the extensive distribution of AST is also can be used in assessment of acute myocardial infarction and skeletal muscle diseases. ALT is mainly from liver, and AST is from liver, also from the heart, muscle, and kidney. The reference range of them are both 10 to 40 units per liter. The elevated level of ALT indicate parenchymal diseases of liver, and the elevated level of AST indicate parenchymal disease of liver and also skeletal muscle diseases and AMI. Okay, the fourth part, LDH and LDH isoenzymes. The function of LDH is to catalyze the oxidation of lactate to pyruvate reversibly. It locates in all tissues. It is a non-specific indicator of tissue damage. As we talked before, LDH has 5 different kinds of isoenzymes. They are composed of H unit and M unit, and they distribute in different tissues and organs. We may know the source of disorders according to the measurement of LDH isoenzymes. The fifth part, bilirubin. There are 2 kinds of bilirubin, conjugated bilirubin and unconjugated bilirubin. The elevated level of conjugated bilirubin is an indication of biliary tract obstruction. It only appears in the urine, okay? And the elevated level of unconjugated bilirubin means hemolytic disorders. If both of them increase, it is likely to be hepatocellular jaundice. So we may know the types of jaundice according to the measurement of the forms of bilirubin. Okay, the fifth part, let's going to learn patterns of liver enzymes and markers for interpretations of disease. In contrast to some disorders such as acute pancreatitis and acute myocardial infarction, there are no enzyme markers that are specific for any single liver disease. As the liver performs its various functions, it makes a number of proteins that pass into the bloodstream and bile. Various liver disorders alter the blood levels of these proteins. When evaluating liver disorders, it is appropriate to consider a panel of markers, sometimes called liver function tests. Liver function tests mean a group of tests that usually includes bilirubin, AST, ALT, ALP, and sometimes GGT and LDH. Liver function tests can reflect various disease processes in the liver, but they do not reflect hepatic reserve for synthesis and metabolic functions. This figure shows some markers and methods for evaluation of liver function and disease, such as ALB, retinol binding protein, pre-ALB, prothrombin time, cholinesterase for normal synthesis capacity, and bilirubin, bile acids, Rose-Banga, and sulfobromelain excretion for excretory function, ammonia, amino acids, serum protein, lipids, electrophoresis, and globulins for metabolic function, antipyrine breath and clearance test, and carbon-14 breath test for drug metabolism. And this figure shows the markers for pathological evaluation of liver function and disease, such as ALT, AST, LDH for hepatocellular injury, bilirubin, ALP, GGT, 5-NT, bile acids for obstruction, the indicators of viral and autoimmune serologies for infections, and CA and AFP for malignancies. Now we are going to learn the patterns of liver enzymes and markers for interpretation of disease. First one, let's take a look at the hepatocellular and obstructive liver diseases. For hepatocellular and obstructive liver diseases, typically, let's take acute injury and cholestasis, for example. For acute liver injury, the most useful enzyme markers are AST and ALT. The highest absolute levels of ALT and AST are seen after acute hepatitis, either viral or toxic. ALP, GGT, and LDH are not markedly elevated and not as sensitive or specific as the combination of AST and ALT. For acute hepatitis, either viral or toxic, the levels of ALT and AST are elevated more than 1,000 units per liter during the early phases. And in hepatitis A virus infection, the level of ALT is elevated in 3 to 4 weeks after infection and return to normal within 8 to 12 weeks. And for hepatitis B virus and hepatitis C virus infection, the preclinical incubation phase is longer, and the levels of ALT and AST may remain normal for 2 to 6 months. And after the acute phase, ALT and AST return to normal within 2 to 3 months. And we have to notice that the extent of ALT and AST elevations do not directly reflect the severity of the disease, nor be correlated to patient prognosis. In chronic liver injury, for example, in chronic active hepatitis, the levels of ALT and AST are elevated 5 to 10-fold than normal. But for end-stage liver disease, the levels of ALT and AST return to normal, or subnormal, but the level is not too high. Why? Because this scenario means the failure or exhaustion of hepatic synthetic function. Okay? In this situation, the hepatocytes cannot synthesize many ALT and AST. Okay? This figure shows the levels of AST, ALT, ALP, and GGT in hepatitis. Obviously, the level of AST and ALT in acute hepatitis is higher than the levels of AST and ALT in chronic hepatitis, and the levels of ALP and GGT in both acute hepatitis and chronic hepatitis are only slightly elevated or kept normal. Okay, the next one, cholestasis. The best markers for intrahepatic and extrahepatic cholestasis are ALP, GGT, bilirubin, and 5-NT. The largest elevations of ALP, usually 4 to 10-fold than normal, are typically seen in obstruction owing to gallstones or malignancy, and in biliary cirrhosis. GGT and 5-NT are more specific in cholestasis. And the levels of AST and ALT are generally only slightly elevated in cholestasis, rarely more than 500 units per liter. Measurement of total and conjugated bilirubin are also important in diagnosis of obstructive jaundice. And this picture shows the levels of AST, ALT, ALP, and GGT in cholestasis. Unlike the levels of them in hepatitis, okay? Here, the levels of ALP and GGT are obviously higher than the levels of AST and ALT. So, ALP and GGT are more specific for cholestasis. Okay, the de Ritis ratio. It is AST to ALT, okay? We call it de Ritis ratio. This ratio is very important for further differentiation of specific liver diseases to judge whether it is acute or chronic, intra or extrahepatic, okay? For normal people, the de Ritis ratio is approximately 1.15. This picture shows the de Ritis ratio in various diseases, okay? The x-axis means the level of ALT, and the y-axis means the de Ritis ratio. When the ratio increases largely, it often means disorders from cardiac or for skeletal muscle, okay? Because AST is numerator, and AST is mainly present in cardiac and skeletal muscle. And for acute hepatitis, the ratio is often less than 1 because in acute hepatitis, the elevated level of ALT is obviously higher than the elevated level of AST, okay? For acute disorders of liver, such as acute viral hepatitis and infectious mononucleosis, the ratio is often less than 1. And for chronic disorders of liver, such as alcoholic liver disease, post-necrotic cirrhosis, and chronic active hepatitis, the ratio is often more than 1 but not too high. And for chronic persistent hepatitis, the ratio may remain normal. And for extrahepatic cholestasis caused by acute passage of a stone, the ratio is less than 1.5. And for intrahepatic cholestasis caused by biliary cirrhosis and malignancy, the ratio is often more than or equal to 1.5. For obstruction, there are some other test items are commonly used. For example, the elevated levels of ALP, conjugated bilirubin, and amylase often indicate the possibility of extrahepatic obstruction is higher than the possibility of intrahepatic obstruction. Okay? The largest increases of the ratio over more than 10 can be seen in myocardial and skeletal muscle diseases. I have mentioned it above. Okay, the markers of alcohol use. Alcohol is metabolized largely by alcohol dehydrogenase. Do you know alcohol dehydrogenase? Moreover said, we also have alcohol dehydrogenase measurement in our clinical laboratory. But the marker, alcohol dehydrogenase, only means your ability of alcohol metabolism, not the marker of alcohol use recently, okay? That means if you have, high level of alcohol dehydrogenase, that means when you drink many bottles of beer, your face may hard to turn red, okay? You may remain calm and clear after drinking many bottles of beer, alright? And so, for medical and insurance purpose, it is important to know whether an individual chronically consumes alcohol or drink many alcohol recently, okay? And here, the most widely used marker for alcoholism is GGT. GGT is highly sensitive to alcohol use. If you drink many bottles of beer last night, today, the level of GGT of you is elevated largely, okay? Significant elevations of GGT are also observed after prolonged drinking episodes of several months or more. However, GGT is not a specific marker for alcoholism. The elevation level of GGT could be seen in many other liver disorders. So some other markers, such as carbohydrate deficient transferrin and fatty acid ethyl esters, are currently being studied. Carbohydrate deficient transferrin is thought to be a useful marker for chronic alcohol use. Fatty acid ethyl esters may be responsible for ethanol-induced liver and pancreas damage. And high concentrations of fatty acid ethyl esters may be an acute indicator of ethanol use within the previous 24 hours, even after serum ethanol concentrations have returned to normal. So it is very significant, okay? And for alcoholic liver diseases, disproportionate increases of AST to ALT are observed. The deriders ratio is often more than 6. From this picture, we can easily find out that for alcoholic liver diseases, GGT and also AST are more specific than ALT and ALP, okay? Okay, the last one enzyme marker, amylase. Amylase is mainly from pancreas and salivary glands, and it also comes from ovaries, intestine, and skeletal muscle. And lipase is an alternative test of amylase for acute pancreatitis, okay? And amylase is a very, very useful marker for diagnosis of pancreatitis, and also for pancreatic duct obstruction and mumps. Okay, in the end, let's do some choice questions. The first one, in 1954, some scientists observed that which marker activity increased after acute myocardial infarction? Which one? Choose D, AST, alright? The second one, which of the following statement is not true regarding primary biliary cirrhosis? A, it is characterized by impairment of bile excretion. B, it has been linked to an autoimmune process. C, it affects men more often than women. D, in patients' serum, high titers of antimitochondrial antibody along with elevation in ALP and aminotransferases can be found. E, inflammation and destruction of bile ducts can be found. Which one is not true? Choose C, alright? PBC has, well, gender discrepancy, alright? It affects women more often than men, not men more often than women. Alright, the third one. Liver function test means a group of tests that can be used to evaluate liver disorders, usually include some biochemical markers, except which one? Choose B, lipase, alright? Lipase is an alternative test of amylase for acute pancreatitis, alright? Not liver function tests. The fourth one, in case of primary hepatocellular carcinoma, the level of which one usually elevated markedly? Very easy, okay? Choose C, AFP. Alright, the next one, which is the most rich enzyme containing organ in our body? Choose E, liver. The sixth one, we can use which one to differentiate the types of jaundice? Well, choose B, bilirubin. Alright, next one. In diagnosing acute pancreatitis, which enzyme is most useful? Choose C, amylase. The eighth one. Which of the following statements is not correct regarding enzyme functions? Which one is not correct? Okay. Alright, choose D. Okay. Most enzymes. The correct answer is most enzymes used for diagnostic purposes have no direct effect on circulatory system. Okay. The ninth one. What is the clinical use of the concentration or activity of enzymes? For all of them. Okay. Diagnosis, differential diagnosis, therapeutic efficacy, and also prognosis. The next one. ALP, GGT, and 5-NT is very useful in diagnosing. Which one? Alright, choose A, cholestasis. Okay, that's all for this class. Here is my email address. If you have any question, please feel free to let me know.